Hello everyone. So today we are going to start a new topic, that is Abruptio Placenta, in this series of video on obstetrics. So we will be talking about Abruptio Placenta, its definition, its causes, its clinical feature, complication, its investigation and management. So let's move forward. So what is Abruptio Placenta? It is also known as accidental hemorrhage, or also known as premature separation of placenta. And the definition clears by itself: the premature separation of placenta. So abruptio placenta is the form of APS, antepartum hemorrhage, where the bleeding occurs due to premature separation of normally saturated placenta. So it is if antepartum hemorrhage where bleeding occurs due to premature separation of normally situated placenta. So what is APS? So we have discussed in previous video. Please write in the comment section the definition of antepartum hemorrhage, and also we have discussed about placenta previa, another important cause of antepartum hemorrhage. So please write the definition of APS, antepartum hemorrhage, and placenta previa in the comment section. Thank you. And now we will be talking about varieties. There are different type of abruptio placenta. One is the reveal type, that is, following the separation of the placenta, the blood insinuates downward between the membrane and the decidua, and ultimately the blood comes out of the cervical canal to be visible externally. It is visible, the blood is visible externally, and it is the most common type. And in the concealed variety, the blood collects behind the separated placenta, or it is collected in between membranes and decidua. The collected blood is prevented from coming out and by the presenting part, which presses on the lower segment, and at times the blood may percolate into amniotic sac after rupturing the membrane. And in any circumstances, blood is not visible outside, and this is very rare type, and it constitutes only 10 to 20% of the cases. So blood is visible. In concealed, it is not, blood is not visible. And here in the mixed type, it is combination of revealed and mixed, where the some part of blood collects inside, that is concealed, and the part is expelled out, revealed. So usually one variety predominates other, and this is quite common. So this is picture showing the concealed and revealed variety. You can see here, the in concealed variety, the blood is collected behind the placenta, or it is collected between membrane and decidua, and the collected blood is prevented from coming out from the cervix by the presenting part of the fetus. And in here, the revealed part, the following the separation of placenta, the placenta is separated and the blood insinuate downward between the membrane and decidua, and finally the blood comes out in the cervical canal. And in abruptio placenta, the maternal bleed is almost always the bleeding is almost always maternal, but the placenta tear may also cause fetal bleeding. It is mostly maternal, and the incidence of the abruptio placenta is 1:100 in 100 deliveries, and depending upon extent, partial or complete, and intensity of placental separation, it is one of the significant cause of the perinatal mortality and maternal mortality. It constitutes around 2 to 5% of maternal mortality, and perinatal mortality 10 to 15%. And abruptio placenta contributes nearly 30% of all antepartum hemorrhage cases, and majority occur in third trimester of patient pregnancy. Now, talking about pathogenesis, depending upon the various etiological factor, the premature placental separation is initiated by hemorrhage into the decidua basalis. The collected blood, that is also known as decidual hematoma, at early phase hardly produce any morbid pathological changes in the uterine wall or placenta. However, depending upon the severity, acute or chronic abruption, the changes in the spiral artery lead to degeneration, infarction, and necrosis of the decidua basalis as well as the placenta adjacent to it. So the histological feature will be chronic deciduitis, decidual vasculopathy, and bilitis might be there, and the rupture of the basal plate may also occur, thus communicating the hematoma with the intervillous space. And the decidual hematoma may be small and self-limiting. The entity is evident only after the expulsion of placenta, and that is known as retroplacental hematoma. And it has to be remembered that the absence of rhythmic uterine contraction plays an important significant role for the blood to remain concealed. And the feature of retroplacental hematoma are depression found on the maternal surface of the placenta with a clot which may be found firmly attached to the area, and the areas of infarction with varying degrees of organization. And when the major arterial spiral arteries ruptures, a big hematoma is formed, and the thrombin generated following residual hemorrhage triggers the action of matrix metalloproteinases, inflammatory cytokine, and the coagulation cascade. And the next thing we have the covalent uterus, that is also known as uteroplacental apoplexy. Covalent uterus, covalent uterus. It is a pathological entity first described by Cavalier, and it is met with in association with severe form of concealed abruptio placenta, and there is massive intravasation of the blood into the uterine musculature up into the serous cord, and this condition can be only diagnosed by the laparotomy. Covalent uterus, and in the naked eye appearance of covalent uterus is let's see picture. Here we can see the picture of covalent uterus. The uterus is a dark port wine color. The dark port wine color, which may be patchy or diffuse, and it tends to occur initially on the cornu before spreading to other areas, more specifically over the placental site. The subperitoneal petechial hemorrhage are found under the uterine peritoneum, and it may extend into the broad ligament, and there may be free blood in the peritoneal cavity or broad ligament hematoma. Same picture, this is posterior surface of covalent uterus, and this is anterior surface. And there may be changes in other organ, like in liver there can be presence of fibrin and not in the hepatic sinusoid can be a important finding. And in the kidney may show acute cortical necrosis or acute tubular necrosis. The precise mechanism is not clear, but maybe due to intrarenal vasospasm as a consequence of massive hemorrhage. The shock proteinuria is probably due to renal anoxia, which usually disappears 2 days after delivery, whereas proteinuria due to preeclampsia tends to last longer. Now we will be talking about etiology of the placental abruption, abruptio placenta. We have almost listed out the 15 different causes of abruptio placenta, and we will discuss all of this one by one and very easy manner. So the exact cause of the separation of placenta, separation is exact etiology of the normally situated placenta remain unclear in majority of the cases. The various risk factor might be there, like prior abruption. Risk of recurrence is around 5 to 17% chance of recurrence, and advanced age of the mother, and various general factors like high parity. The more than or equal to 5 pregnancy, it has the this is 5 to 17% is next one important cause is prior abruption. In the prior abruption, the risk of recurrence is 5 to 17%. The 5 to 17% chance that it will recur. Prior abruption is one of the important risk factor. Next is high parity, more than or equal to 5 for pregnancy. It has the 3 times risk more common than in first birth. And the advancing age of mother is another important cause. Advancing age of mother, poor socio-economic condition, low nutritional state, then the smoking, which causes vasospasm, is another important cause. And the hypertension in pregnancy is one of the very important cause of most important cause of abruptio placenta. The preeclampsia, gestational hypertension, essential hypertension, all are associated with abruptio placenta, or 10 to 50%. And mechanism is the hypertension causes spasm of the vessel in the uteroplacental bed, that is decidual spiral artery, and it causes anoxic endothelial damage, and it causes which causes rupture of vessel and extravasation of blood in the decidua basalis, and it causes retroplacental hematoma. And the traumatic separation of placenta usually leads to marginal separation of the with escape of blood outside. The trauma may be external cephalic version, especially under anesthesia using a great force, road traffic accident, blunt trauma or blow on the abdomen, and the needle puncture at amniocentesis might cause abruptio placenta. And even sudden uterine decompression of the uterus lead to diminished surface area of the uterus adjacent to the placental attachment and result in shearing of the placenta, shearing, shearing of the placenta. And the clinical situation are the following: delivery of the first baby of the twins and various conditions like following following deliveries of first baby of twins, sudden escape of liquor amnia in polyhydramnios, and the premature rupture of membrane. And in these all of the cases there is sudden uterine decompression, and that leads to the abruptio placenta. And short cord, either relative or absolute, can bring about placental separation during labor by mechanical pull, short cord. And the supine hypotension syndrome, and there is passive engorgement of the uterus and the placental vessel and resulting in rupture and extravasation of blood, supine hypotension syndrome. And the placental anomaly, the circumvallate placenta. We have the circumvallate placenta and the sick placenta. It is a poor placentation as evidenced by abnormal uterine artery. Doppler waveforms is another risk factor, and folic acid deficiency even without the evidence of overt megaloblastic erythropoiesis. And the uterine factor like placenta implanted over septum, septate uterus, or submucous fibroid. And another is torsion of uterus. Torsion of uterus leads to increased venous pressure and rupture of vein with separation of placenta. Torsion of uterus. And the next is cocaine abuse. Cocaine abuse leads to increased venous pressure and rupture of membrane, rupture of vein with separation of placenta. Cocaine abuse is associated with increased risk of transient hypertension and vasospasm and placental abruptio. Cocaine leads to hypertension, and that leads to cocaine abuse. And next is thrombophilia. Both the inherited and acquired are associated, and hyperhomocystinemia is associated with recurrent abruption. We have the clinical classification of the abruptio placenta. Depending upon the degree of placental abruption and clinical effect, cases are graded as grade 0, 1, 2, 3. And in grade 0, there is the clinical features are absent. The diagnosis is made after inspection of placenta following after the delivery. And in grade 1, there is 40% in the grade 1 consists 40% of the cases. The vaginal bleeding is slight. The uterus is irritable and tenderness may be minimal or absent. Tenderness is absent usually, and the maternal blood pressure and fibrinogen level are unaffected. Usually what happens is that the fibrinogen decreases in abruptio placenta due to excess consumption, as there is massive hemorrhage, and due to excess consumption of fibrinogen there is hypofibrinogenemia in abruptio placenta. But where here in grade 1 there is no fibrinogen level is not affected, and fetal ultrasound is good in grade 1. And in grade 2, 45% of the cases there is mild to moderate bleeding, and uterine tenderness is almost always present, and there is rise of the blood pressure and the pulse is increased. Maternal blood pressure blood pressure is maintained but the pulse is increased, and the fibrinogen level might be decreased. And here shock is absent, and the fetal the grade 2 causes fetal distress or even the fetal death can occur. And in grade 3, in 15% of the cases there is moderate to severe bleeding, or there may be concealed, and the uterine tenderness is marked, and the shock is very pronounced, and and fetal death is ruled. Fetal death will inevitably occur, and associated coagulation defect or anuria may even complicate the matter. And what are the different clinical manifestations of hemorrhage in abruptio placenta? Firstly, the blood may accumulate behind the placenta when it is totally separated from uterine, except at the margin, and it has the concealed type, as we have already discussed. And the blood may dissect downwards in between the membrane and the uterine wall and ultimately escapes out through the cervix, or may be concealed by the pressure of the fetal head on uterine segment, and it is reveal type. And the blood may gain access to amniotic cavity after rupturing membrane, and the blood may percolate through layers of myometrium up to the serous cord known as covellar uterus. And ultrasonographic localization of hemorrhage, and it may be retroplacental between placenta and myometrium. It in 50% of cases there is fetal mortality, and subchorionic between placenta and membrane, and the preplacental between placenta and amniotic fluid, within amnion and chorion subamniotic. And the fetal prognosis depends upon size, the type of the hematoma, retroplacental hematoma, and retroplacental hematoma has the worst prognosis with high mortality, and subchorionic small site hemorrhage have less fetal mortality. Subamniotic is clinically less significant. Now, talking about clinical feature of the abruptio placenta, the clinical feature depend upon the degree of separation of placenta, type of abruption, whether it is acute or chronic, and variety, concealed or revealed type, but it may be very deceptive in posteriorly implanted placenta. And acute abruption, concealed variety typically present with abdominal pain, vaginal bleeding, uterine contraction, and tenderness. We have the different clinical feature of revealed and mixed variety of abruptio placenta. And the symptoms of the revealed variety of abruptio placenta is that the abdominal discomfort or pain followed by vaginal bleeding. In the revealed type, abdominal pain or discomfort followed by vaginal bleeding, and whereas the bleeding, the character of the bleeding is slight to moderate bleeding, there is slight to moderate bleeding, and continuous dark color. Whereas in mixed variety, the abdominal acute intense pain followed by slight vaginal bleeding. Here vaginal bleeding is prominent, but it is slight, only slight vaginal bleeding, and pain is more prominent in the mixed type, and the bleeding is slight, and the continuous dark color or blood stained serous discharge might be there. General condition is proportionate with the visible blood loss. Shock is usually absent, and the shock may be pronounced, which is out of proportionate with visible blood loss. As blood is, as the hemorrhage is not visible, the shock is out of proportion with visible blood loss. And the pallor is related with visual blood loss, and pallor is usually very severe out of proportion to visual blood loss. And the feature of preeclampsia is it may be the preeclampsia is maybe absent or frequent association, and the uterine height proportionate to the period of gestation is uterine height is equal to period of gestation. Here maybe uterine height may be disproportionately enlarged, and globular height is more than period of gestation because of size. And the uterine field is the normal field with localized tenderness and contraction frequent and low with the local amplitude. Here the tender, the in mixed type there is tender, tense, and rigid type of uterus is there. The fetal part can be identified very easily in reveal type. In it is difficult to make out in mixed variety. The fetal heart sound is the fetal heart sound is usually present, and it is irregular due to hypoxia, and it is fetal heart sound is usually absent as fetus is already dead in the mixed variety. And urine output is normal, and urine normal is usually diminished. So mixed variety is more dangerous type. And laboratory test, the blood hemoglobin percent has low value, and it is proportionate with blood loss. It is markedly lower and out of proportion with visible blood loss, and the coagulation profile is usually unchanged. Where the variable change in the changes in the coagulation, there might be consumption coagulopathy. The clotting time is increased more than 6 minutes. The fibrinogen level is low, less than 150 per milligram per deciliter. The platelet count is low. There is as consumption coagulopathy. There is increased partial prothrombin time. There is increased fibrin degenerated product, and D dimer is elevated. And Urine for protein maybe absent, and it is and the urine as the proteinuria. And the confusion in diagnosis is with placenta. Differential diagnosis is placenta previa, whereas acute obstetrical, gynecological, and surgical complication might be there. So we will list out the differential diagnosis of these two varieties. The differential diagnosis is the revealed type. There may be occasional diagnostic difficulty with placenta previa. Placenta previa is a differential diagnosis, and the difference between placenta previa and abruptio placenta is discussed in another video. And the mixed and concealed type, the variety is often confused with rupture uterus. The one differential diagnosis is rupture uterus, rectus with hematoma, appendicular or intestinal perforation, acute hydramnios, and tonic uterine contraction. These are the 5 differential diagnoses of mixed or concealed type. Diagnosis of the abruptio placenta is mainly clinical, and ultrasound, sonography, and MRI might be helpful. And talking about prognosis, the prognosis of mother and baby depend upon the clinical type of the abruptio, revealed, mixed, or purely concealed type, the degree of placental separation, and interval between separation of placenta and delivery of the baby, and the efficacy of treatment. The hypofibrinogenemia and consumption coagulopathy are often observed with the severe abruption. The perinatal morbidity and mortality are very increased. The perinatal death is increased by 10 times, and the bleeding in the placental abruption is almost always maternal. And the fetal bleeding is observed only with traumatic variety of placental abruption. The chronic abruption often present with chronic placental inflammation and dysfunction. And the maternal morbidity is very high. The maternal mortality varies from 2 to 8%. However, with better understanding in management of shock, coagulation failure, renal failure, maternal death has been reduced markedly. And some cases who might manage to survive may develop feature of ischemic pituitary necrosis, also known as CN syndrome later on. And there might be failure of lactation. Now talking about management, the prevention, first one we have the preventive measure. The prevention aims at elimination of the non-risk factor that are likely to cause, likely to reduce placental separation, the correction of anemia during antenatal period so that the patient can withstand blood loss, prompt detection of uh, and institution of therapy to minimize the grave complication like shock, blood coagulation disorder, and renal failure. And non-factor elimination are the prevention of non-risk factor likely to cause placenta separation, or if we can prevent this factor, then we can prevent the placenta previa. And that is, one is early detection and effective therapy, and other hypertensive disorder in pregnancy, early detection and therapy of preeclampsia and other hypertensive disorder. And the needle puncture during amniocentesis should be under ultrasound guidance, and there should be avoidance of trauma, especially with the forceful external cephalic version under anesthesia. There should be avoidance of trauma. There should be avoidance of decompression of the sudden decompression of the uterus in acute and chronic hydramnios. Amniocentesis is preferable to artificial rupture of membrane. And to avoid supine hypotensive syndrome, the patient is advised to be lie on the left lateral position in latter month of the pregnancy. And the routine administration of folic acid from early pregnancy might be the useful, but it is doubtful and controversial. And the treatment in the hospital, which first of all we should do the assessment of the case. That is done by mainly accessing the amount of blood loss, maturity of the fetus, the labor, whether the patient is in labor or not, and usually the labor starts, and the presence of any complication, type and grade of placental abruption. And emergency measures like blood is sent to the hemoglobin and hematocrit estimation, and the coagulation profile, fibrinogen level, fibrin degradation product, prothrombin time, activated partial thromboplastin time, and platelet are to be sent. ABO and RS grouping and urine for detection of protein, and ringer lactate solution drip is started with wide bore cannula, and arrangement for blood transfusion is made for resuscitation, and close monitoring of maternal and fetal condition is done. That is emergency. And the management option, we have the 3 types of management option. One is immediate delivery, management of complication if there is any, and the expectant management is another rule. And expectant management is very rare. This flowchart shows the scheme of management of abruptio placenta. Here, if the patient presents abruptio placenta, we will access the general and abdominal examination, fetal status of clinical, and ultrasonography of the fetal. Ultrasonography, grade for abruption, hemoglobin percent, hematocrit, platelet count, coagulation profile, and ABRS group. We have to access all of these, and the emergency measure are infusion of crystalloid, blood transfusion, periodic coagulation profile, urine output monitoring, and fetal monitoring electronic. And we have to do resuscitation and find out whether that is revealed or concealed type of abruptio placenta. And if the patient in the revealed type, if the patient is in labor, the most patients are in the labor following the term pregnancy. The rupture is accelerated by low rupture of membrane. The rupture of the membrane with escape of liquor amni accelerate the labor and increases the uterine tone also. The oxytocin drop may be started to accelerate labor when needed. And vaginal delivery is favored in cases with limited placental abruption. Fetal heart rate tracing is reassuring, and the facilities for continuous electronic fetal monitoring is available. And the prospect of vaginal delivery is soon or placental abruption with a dead fetus. And if the patient is not in labor, the bleeding continues, and the grade more than greater grade 1 abruption, the delivery is either by induction of labor or by cesarean delivery. The induction of labor is done by low rupture of membrane, artificial rupture of membrane. The oxytocin may be added to accelerate the delivery, and the labor usually starts soon in the majority of the cases, and deliveries are completed very quickly in 4 to 6 hours. The placenta with varying degree of amount of retroplacental clot is expelled, and most often simultaneously with delivery of baby. The injection of the oxytocin 10 international unit IV or intramuscular or injection methorzine 0.2 milligram IV is given with delivery of baby to minimize the postpartum blood loss. And oxytocin should be used to improve the uterine tone along with blood transfusion. And delivery, the cesarean, the indication for cesarean delivery are that severe abruption with live and viable fetus, appearance of adverse feature like fetal distress, falling fibrinogen level, oliguria, if the amniotomy could not be done, and prospect for immediate vaginal delivery is very not possible. And the anesthesia during the cesarean delivery is general anesthesia avoided as there is hemorrhage. So the expectant management in the case of placental abruption is an exception and not the rule. Expectant management. And in the concealed variety, the delivery is either by again cesarean delivery or that. And we have to oxytocin to be continue to improve uterine tone along with blood transfusion. So we have already discussed this table, this management chart, and this is important for writing in MBBS Final exam. Now we will see the complication of abruptio placenta and its management. The complication could be in the revealed variety. The maternal risk is proportionate to the visible blood loss, and maternal death is very rare. But in concealed variety, the following there are various different complications occur either singly or in combination. First one is hemorrhage, which is concealed inside uterus, and it may be intraperitoneal or broad ligament hematoma. And the shock, second one is shock. The shock may be out of proportionate with the blood loss, and then the need of cesarean delivery, need of blood transfusion and amniotic fluid embolism is very high. And the blood coagulation disorder, consumption coagulopathy, pituitary failure, Sheehan syndrome, organ damage like oliguria, renal failure is very high due to hypovolemia, serotonin liberated from damaged uterine muscle produce renal ischemia, and acute tubular necrosis in very severe case, cortical necrosis and renal failure. And the postpartum hemorrhage can occur due to atony of uterus and increased serum fibrinogen degradation product. And the puerperal sepsis might be there, and there might be death also. These are the complications in the mother. And in the fetus there may be revealed type, there is the fetal death is around 25 to 30%. In concealed variety, the fetal death is high, that is 50 to 100% cases, and death are due to prematurity and anoxia due to placental separation. The fetal mortality in cases with retroplacental hematoma is 50%, and fetal hypoxia lead to periventricular leukomalacia and sudden infant death syndrome, fetal death. And neonatal, the prematurity and other and its related complication might be there in neonate. The major complication of the abruptio placenta are hemorrhagic shock, disseminated intravascular coagulation, renal failure, and uterine atony, and postpartum hemorrhage. And the management of the complication is correction of hypovolemia, that should be corrected early. The blood pressure may not be correct guide for accessing shock, at it may be high due to severe degree of vasospasm. And irrespective of patient general health, at least 1 liter of blood transfusion should be minimum when the diagnosis of concealed accidental hemorrhage is made. And the best guide to monitor the patient is use of central venous pressure, which is maintained at 10 centimeter of water, and hematocrit should be at least 30%, and urinary output should be more than 30 ml per hour. And disseminated intravascular coagulation and release of tissue thromboplastin in placental abruption causes consumption coagulopathy, and diagnosis made on coagulation profile assessment. Treatment is to restore the hematologic deficiency, and the fibrinogen level should be more than 150 milligram per deciliter, and 1 unit of fresh blood raises the blood volume and the fibrinogen level approximately by 12.5 milligram per 100 ml, and platelet count is increased, and that may be helpful. So blood transfusion is one important management for managing complication. So thank you. That was all about abruptio placenta. And in next video we'll come up with new topic in obstetrics. Thank you.